So, first one is true or false, hair loss is purely genetic.
False.
Number two, can women experience the same type of balding as men?
Similar.
Does washing your hair often or too often cause it to fall out?
No, it can give the perception it's falling out more, but it's not causing it to fall out.
Thank you. Can intentional weight loss or the use of glucagon like peptide receptors that GLP-1 medications like Ozempic, Wegovy, Manjaro, Zepbound, and so on lead to hair loss? Hi, everyone. Welcome to another episode at Hormones and Hope. This is Dr. Chhaya Makhija, and I have an amazing specialist. Our guest today is coming all the way from Northeast, and she's a dermatologist. So my first skin specialist. So I'm so excited about meeting and talking to Dr. Brenda Dintman. She has more than 30 years, so 3 decades of clinical experience in both medical and cosmetic dermatology. And she's one of those who is not just there for your skincare, but also believes in that integrative medicine. And today she is going to share a lot about her expertise on specific topics. And I have outlined some questions about hair loss. So, men and women, come on, you got to listen to this entire episode because there's a lot of wealth and lots of gems as we learn more from Dr. Brenda. So, welcome, Dr. Brenda.
Thank you.
So, please share more about yourself, where you are, where do you practice, anything that rings a bell with bringing that passion for dermatology and clinical care, or anything fun about yourself.
Yeah, I'm in Vienna, Virginia, Northern Virginia, and I've been here for over 30 years. But in the last 6 years, I've had my own practice again called Derm Utopia. And our concept was to have your dermatologist available anytime, anywhere. So we had an app that was created in 2012, do virtual care and lots of in-person care. And I would say our biggest philosophy is to try to get people to love the skin you're in. That which means to us that we care a lot about what's inside of you and what's affecting your skin as much as we care about what we're seeing.
That is so beautiful. So, someone had told me or asked me that what does internal medicine mean? And that was while I was in my residency. And I was like, well, I went on with the scientific description of what internal medicine is. I was like, well, you could have just explained it internal. So you look inside the human body and then help them heal. So I'm bringing this back because it correlates with what you just said. It's not just the outside, but inside and what's going on. So very beautiful. So, Dr. Brenda, when we start our episode, it's usually a few rapid fire questions, which could be yes, no, one liners. It depends. And if you feel like there has to be a more detailed answer or response to that particular rapid fire, we can start with those after these questions. So, you ready?
Okay. Yeah.
All right. So, first one is true or false, hair loss is purely genetic.
False.
Number two, can women experience the same type of balding as men?
Similar.
Does washing your hair often or too often cause it to fall out?
No, it can give the perception it's falling out more, but it's not causing it to fall out.
Thank you. Can intentional weight loss or the use of glucagon like peptide receptors that GLP-1 medications like Ozempic, Wegovy, Manjaro, Zepbound, and so on lead to hair loss?
Absolutely.
Thank you, people hearing this. And now we get into the real answers. So, Dr. Brenda, since we were talking about hair loss in our rapid fire, can you break this down? Like, what is the natural cycle for both men and women? And what is abnormal or pathologic a symptom of hair loss?
Well, I would say the thing we see the most common in women is telogen effluvium. And this is the hair loss that we were always taught happened 3 to 4 months after having a baby. But I've always taught my patients it can be anything. It could have been you had the flu, you had a big car wreck, you took your final exams. So anything that's extremely stressful on your body and your psyche, we often see all the hairs go into the actively falling out phase. And this is called telogen effluvium. We can see this in men, but it's most common to see the male pattern androgenic alopecia, the typical thinning here and here, which we can even see in people's 20s. So we know now that people have combinations of hair loss, and it's been really an eye opener in the last 5 years. I'm not sure why, but during COVID, we learned a ton about hair loss.
And anything that stands out for you, where we did not know much before the COVID era or the pandemic?
I don't know if it's because we were seeing such high volume that made a lot of us start to obsess about why. We knew there was stress involved. We knew there were physical factors, maybe even nutritional changes that people had because of what they were experiencing. But it happened pre COVID, if you had COVID, if you had the vaccine, if you didn't. But it just led us into a very interesting phase to study more about vitamin supplementation, protein, and ways that we could make hair loss, go or improve.
Fascinating. With this, could you emphasize or shine some light on both men and women? Like, is there a natural regression as we approach midlife or around age 40, 45 for both men and women? Is there a change in how the hair growth cycle is or hair loss?
I mean, I think that with men, we see it more just being a steady progression of the male pattern hair loss. And that's where the drugs such as minoxidil and finasteride, which was Propecia, really to play 20 years ago. It was 20 years ago that Rogaine came out, when it was turned into a foam, into a liquid, and that's when the studies were done. I think with women, we've learned more that it's multifactorial. I really think of it like a garden. I really think you have to have the soil healthy, which for me is the nutrients, the protein in your body, vitamin D, all that supplementation to make the scalp healthy so that you can have the hair growth. And then we actually look at the scalp to make this sure the scalp doesn't have any evidence of scarring, redness, little pimples or blisters that are kind of keeping that plant, almost like a bulb, from coming out. So it's really been helpful to think of it in a multifactorial way, not just let's take one thing or let's do one vitamin, because you got to have the garden healthy, you have to have the plants healthy, and then the existing plants will get better with treatment in addition. For example, with minoxidil.
The effects of any effects of estrogen and progesterone in these women, which who are perimenopause, menopause, because if postpartum can cause changes in our hair, estrogen progesterone fluctuations in women with polycystic ovarian syndrome, premature menopause, in the perimenopause, menopause. Do you see a larger group of consultations in this era? And how do you go through explaining them the etiology or the causes, and how do you approach their care?
Yeah, I think thinking about postpartum is a good example because we know that people are going to lose hair. We know it's from the rapid drop of estrogen, progesterone, but we have to look at other factors as we do in all patients. Is their ferritin low? Are they walking around anemic? Especially if they're breastfeeding, could they be needing more nutrient support, need to stay on their prenatal vitamins? And are they low in vitamin D? Is their thyroid being affected? Are they getting elevated thyroglobulin antibodies that is could as we know, as we see, we can see excess hair loss with a hyperactive thyroid as well as a underactive thyroid. So to me, again, you have to look at the whole picture. I think the same thing happens perimenopausal. We start having fluctuations in the estrogen and the progesterone. So we see more of the shedding and telogen effluvium at that time. But I know personally, many of us developed extremely heavy periods when we were perimenopausal. We developed adenomyosis, which is the thickening of the and irregular shedding of the lining, and it was quite stressful. And also, many times we would check the ferritin level, although the normal is 20 to 200, it would be running around 10, 15, 20. That's not enough for hair. We like to see the ferritin at a level of more 50 to 100. So even though women were not showing they were anemic on their regular TBC, the regular tests we do to see if you're anemic, their ferritin was low. In my mind, I was thinking the body is having to fight awfully hard to keep you from being anemic. And what does it shed first? Hair and nails. So I think that that's a clue. As you go through menopause, then that lack of estrogen, progesterone, the hair definitely changes texture. it becomes brittle, it becomes thinner. There's probably not as much of it, but also the quality of the hair is not as good as it was in our 20s and 30s.
That's beautifully explained. Yeah. So iron deficiency is what you're focusing on these patients. You commented about thyroid. So yes, hyperthyroidism, which is overactive, or hypo or underactive, two extremes. But yes, they both can impact our hair, skin, and nails if not treated. But how do you help your women understand the timeline that, here, let's treat your vitamin D or let's treat your iron deficiency in individuals with hyper or hypothyroidism while they're undergoing active treatment? What's the timeline that they could anticipate that, okay, now I'll start getting the new hair growth back?
Yeah, that's a great question. I always tell them it takes at least 3 to 4 months. On the time period, I think of it as we have to have the tank full with the vitamins, the nutrients, the protein, and the stabilization of whether it's your thyroid or you're anemic, and then you'll see growth. I try to be optimistic and say 3 to 4 months, but also realistically, it probably takes longer if it takes longer for someone's levels to get up in case they have any kind of absorption problems with vitamin D or also with iron or don't tolerate. But I think the biggest thing is giving people hope. And if we see them back and we see little baby hairs growing, we can complement that with using topical minoxidil combinations. There are lots of compounds to be made with minoxidil, spironolactone. We add tretinoin, which helps it absorb better, and customize it to them. Most people don't like using it. It's the hardest thing. So we were using PRP a lot for about 3, 4 years. I think most of us feel that PRP is a nice complement to vitamins and to other topicals, but it's not a home run by itself.
Yeah, so it is a combination that you're actually using. I wanted to touch base on, so say you discover a patient who is iron deficient. Are you sending them back to the primary care physician that, hey, you're iron deficient, work with them in terms of their iron supplementation. Maybe they'll need iron infusion. Do you do the same thing with vitamin D? Do you do the same thing with thyroid? So how does it work for a patient, when they're seeing you for hair loss? And then how is the care directed after that? Once you've identified the etiology.
Yeah, I mean, I think in a perfect world, you'd be working closely with their endocrinologist or their primary care physician or GYN. I usually take a history and make sure they've had a colonoscopy if that's the appropriate age. I ask questions about whether their periods are heavy and, what birth control they're on, and try to take a little bit of a history and then partner with their existing physicians. Not always easy to get people in to see someone. It's very difficult to get in to see an endocrinologist, which would be preferable. Um, but I think those basic questions will guide us. Like, when was the last time you had a pap smear? Are your periods heavy? Have you had a colonoscopy? Are you having any blood in your stool? We recently had a patient that was about 65, started having new onset of hair loss at 65, did some history, did some basic blood work. She was anemic, B12 was low, and she had pernicious anemia. So she was diagnosed by her gastroenterologist, and now her hair grew back. Her other vitamins are absorbing better. So I think as a dermatologist, we're pretty used to thinking of the systemic signs and causes of skin and hair and nail problems. So we dig deep first and then kind of guide back instead of just saying, please work this person up.
Yes, absolutely. We just need more of you. Uh, we're everywhere. Yes. Another thing that I always get a common question or a referral from dermatologist, and you actually mentioned about it, that when you're testing for antibodies in the thyroid realm. So, when we're diagnosing hyper and hypothyroidism, it's mainly based on TSH, free T4, and free T3 in several cases. And then comes thyroglobulin. Thyroglobulin is a protein. So, if I have a thyroid which is intact, it is supposed to produce that protein. And the lab ranges are only created for patients who don't have a thyroid gland. So if someone's thyroid is out, taken out, resected, or they had a surgery, and if I'm looking at their thyroglobulin, it should be undetectable because they're not producing any protein. So you've done the early part of the detective work, which was very beautiful. Like I don't see this very often. And then you're at least getting to that, okay, there must be some autoimmune background, which might explain the hair loss. So thank you for sharing that part of the expertise also. Now I wanted to touch base again on the minoxidil that you've been talking about in treatment. Can you explain what it is? And do you have a preference? Or if you don't have a preference, is topical better, oral better? Or when do you use topical? When do you use oral? Because topical is available over the counter. Is there a difference between what men use versus women use? And how do you bring all this in your clinical practice?
Originally, it was developed for men exactly like 21 years ago, and it was 5% minoxidil, and that's what became known as Rogaine. It was supposed to be applied twice a day for life. So, of course, that's always been a thing. The first thing someone says, I don't want to do this for life. But there's so many things we do for life. We take our blood pressure medicine, we take our diabetes medicine, we may take vitamins. So you kind of have to calm that down. Even probably 10, 15 years ago, the experts in hair and dermatology across the country immediately put women on 5%. We knew that 2% was not effective, but we also knew that the studies were not going to be done in women. There was enough financial support for that, but it was safe to use minoxidil on women. And then I would say in the last 5 years, we started having compounds made, and that's where we added 7% minoxidil, finasteride, spironolactone, all things that we knew supported the hair. And I would say the most I can get patients to use it is once a day because it can be greasy and not fun to use. They have to make a little part, put it on the scalp, make a lot, do it every day. We do use oral spironolactone just like we do for acne. We use it also for hair loss. And if we find that people have an androgenic component like high androgen or high testosterone component to it, and we can combine it with other things. But I would say the biggest thing that's changed in the last 2 years is we've all gone full circle and we're using oral minoxidil again. And they figured out minoxidil worked, but the doses were like 15 milligrams when you're treating blood pressure. Now we use for a woman, they come in 2.5 milligrams. We use a half of a pill. For men, we start at 2.5 and we might go to 5. And I see hair growth even with a half a pill a day go to 2.5, some people will start to see excess hair. We don't seem to see people getting swelling of the legs, lightheadedness. I have everybody from like a 40-year-old to an 85-year-old on minoxidil now. I would think the biggest thing that's changed is to learn that biotin is not helpful for hair loss. It may make your nails a little bit stronger, but we've taken out almost completely out of most supplements because not only does it not work, it also can affect your thyroid studies when you go to get checked to see if you're hypo or hyperthyroid. It can affect that test and also can affect your troponin test, which is the test we do if they think you're having a heart attack. So biotin's out. There's a little bit left in most supplements, but the most important thing is to use a hair and nail supplement that is effective, not just plain biotin.
Yeah, wow. So just half of the 2.5, even that would bring about that change or effect or response for hair.
Yeah, and just like the garden analogy, the hair, you'll see more hair growing and you'll see the existing hair get thicker. Start to see filling out. And these are people sometimes that you've been able to see their scalp with little baby hairs for like 15 years. So they have that hair for a long time. But we talked about you have to look at the health of how healthy the scalp looks. Does it have oil or a lot of seborrheic dermatitis, a lot of yeast, or does it have evidence of scarring, which is much more challenging when we are people with frontofibrosing alopecia, where you literally will see that their scalp line used to be here, now it's to here. It's shiny. There's no hair follicles. Still a big mystery in dermatology. Why is it happening? Why are we seeing more? And what can we do to help them?
Wow. So there's probably some environmental or toxic. We have a whole group of endocrine disruptors for infertility, like with all the plastics and cans and products we use. I don't know if that's been studied yet for hair.
Yeah, they kept saying it could be sunscreen, but it doesn't make sense to me because most of us don't put our sunscreen into our scalp. We it so I think there's still a lot to be learned. But yeah, I kind of agree with the endocrine disruptors like the benzophenones and I stay away from those in sunscreens. I like to use mineral based because I we found those in the endometrial tissue. So why do we need to use them? I don't think.
Yes, yeah. So can you give your 2 cents on this one, the mineral based versus the chemical ones, and what do you recommend your patients for the sunscreen?
I love mineral-based sunscreens. I like them for practical reasons that they stay in place better. I like it to be tinted for women because it helps you from getting pigmentation, melasma. It protects you from blue light. And also, if it gets in your eyes, if you're a tennis player, pickleball player, if you're an athlete, it's not going to burn your eyes. So those are my favorites. I'm not saying there aren't great other sunscreens. We're waiting for things from Europe that are not here yet. There's a great La Roche-Posay product there. We're waiting for it to come, but we have not had some chemicals released here that are equally effective in the US.
So, Dr. Brenda, if you had to give us an outline of what kind of patients you see, you talked about cosmetic as well as the new technology that you've been using. You have an app. How can patients reach you? Which states do you provide medical care to? And what's upcoming in the future for you?
Provide care in Virginia, primarily Maryland and Tennessee, and previously in New Mexico and Hawaii. We may do that again. People can reach us through texting us. We do use a lot of technology to text and schedule for patients, and we you can follow us on our Instagram, Facebook, and also read our blogs. And our goal is really to provide a more holistic approach to skincare. Like I said before, it's really a lot about what's going on within your body, whether it's like we've talked about, are you anemic? Do you have a rash? Are you brewing lymphoma? We picked up lymphomas. We picked up pernicious anemia, which is a absorption problem, GI tract. So we really try to look and listen to the patient and also get them to the right people. Try to do it all myself, but I want to make sure that they're not there just for their skin exam and ignoring something more important like their thyroid or like their cardiology problem. So this is a real team approach. We have all pre-meds or pre-PA students, so they're super motivated. We're always reading the literature, keeping up, and I think that's what makes us really enjoy practicing dermatology.
Yes, yes, absolutely. I share the same with you. Yes, we're always in this learning and growing phase. So thank you so much. And what's your handle for the social media?
So it's Dermatopia Dermatologist, and we'll be expanding to a wellness clinic, adding weight loss and menopause to complement because we're seeing a lot of skin changes with people that are going through weight loss and hoping to support them so they don't lose the facial volume, so they feel good about themselves. Again, now they're feeling good from within. We need to have them feel good, support their hair and their skin also through the process.
Mm-hmm. Oh, absolutely. Since you were mentioning about it, what options or what discussions do you have for patients who've been on GLP-1 either for diabetes or for weight changes or management because of overweight, obesity? Do you have any dermatology procedures or care that needs to be or actively be talked about or discussed to the patients?
Yes, I mean, I think you would agree. We want them to keep their protein intake up because that's what supports the hair and the skin. Always sunscreen to protect your skin from getting losing more collagen, elastin in the skin. And then I like them to get help along the way. Don't just you've lost the weight, your goal weight. Many times people will need volume added with small amounts of filler in the face. And now we'll also do something called hyperdilute radiesse, where we thin it out, water it out, because we want to stimulate your own collagen to grow. I'm seeing just a a lot of loss of facial fat here. And I think that that can be sort of disturbing to patients. And we will see patients that will have sometimes dryness or itching, so we can support them along their journey with their weight loss. We also can work on the texture of the skin by using something like Laze ND Ultra, which helps with sun damage and rejuvenating it. And even radiofrequency will help with some tightening along the jawline.
Wow, that's very much holistic and comprehensive. This was amazing. Great insights, Dr. Brenda. And we would love to have you back on our podcast with another topic. So, viewers and listeners, if you wanted to touch base on a specific dermatology topic which coincides with the Hormones and Hope podcast, please send us questions and we would love to have Dr. Brenda again. Thank you so much.
Thank you.